As per recent estimates, there is only one donor cornea available for 70 needed. It's a huge shortage. Increasingly, eye banks are retrieving tissues from pseudophakic donors for DMEC, although it is a technically difficult job to harvest DMEC grafts from them. Look at these two images of a 68-year-old pseudophakic gentleman 2 years after cataract surgery. Imagine if he was a cornea donor. Do we harvest the grafts and use those? The ongoing COVID-19 pandemic to now endemic status has taught us many things, including the use of pseudophakic donor for DMEC. In a tissue shortage scenario, this potentially reduces waiting times. Otherwise, a bullous keratopathy may be inoperable within a few months for various reasons. Do not waste. Harvest and use good pseudophakic donors for Desc membrane endothelial keratoplasty. The authors have no financial interest in this video presentation. In this teaching video, we will show how to prepare DMEC graft in corneas retrieved from different types of cataract surgery, after phaco, after manual small incision cataract surgery, and after conventional extracapsular cataract extraction. Our first situation is pseudophakic donor after phaco. We start by staining the endothelial surface, and the main incision and the side ports are then identified from the epithelial side. A template mark, usually of 8.5 to 9 mm, is placed outside those incision marks. Flip the cornea with endo up and relocate those incision marks. Now a 9 to 9.5 mm light trephination corresponding to the template mark is made. This is usually eccentric in pseudophakic tissues. After staining the trephination mark, the peripheral desmates and loose iris tissues are removed. Now proceed to loosen the peripheral attachment of the DM endothelium complex, maybe 6 to 9 clock hours in the areas opposite to the incisions. Make sure not to cross the incision or the side ports. The peeling is initiated from the opposite side of the main incision, and care is taken to not cross the side ports. In such a situation, the hinge will be larger than conventional preparation. A 3 mm stromal punch is made and the DM is floated back. The cornea is flipped, the DM is dried through the stromal window, and the S mark is placed. The cap is replaced, and again we flip to endo up orientation. Now we move to the final 7.75 mm final trephination. Trypan blue staining is done again, and the peripheral redundant DM endothelium is removed. The final peeling is done very gently with forward and side to side simultaneous movements. This is followed by trypan blue staining for a minute. BSS wash is given, and the graft is then shifted to a petri dish filled with BSS. Now the graft is ready for loading, injection into the anterior chamber, unfolding, and finally air injection. Please note the location of the main incision and side ports after the graft preparation. Moving on, the second variation is pseudophakic donor tissue after manual small incision cataract surgery. Again, we begin by staining the endothelium with trypan blue and identification of the large main incision and the side port. The template mark is done from the epithelial side outside that of the incision. The SICS incisions are usually more towards the limbus. A light 9.5 mm trephination is made on the endothelial side, followed by trypan blue staining. Peripheral separation of the DM edge as before. Again, care is taken not to cross the main incision or the side ports. Peeling is initiated from opposite to the main incision, maybe 50 to 60%, and also stopping at the side port. The 3 mm stromal window is made, the cornea is flipped and S-stamp is placed, and we move on to the final trephination of 7.75 mm. The peripheral DM is removed and the final peeling is completed. Then finally, and it's ready for loading. The third scenario is after conventional ECCE, which is rarely seen nowadays. Again, the same principles are followed. The staining is started from the endothelial side. Here it might be difficult to identify the incision mark since it is close to the limbus. So the template mark is done at the center, and naturally the initial 9.5mm light trephination is also placed centrally. Now with further staining, we can see the large peripheral incision as indicated by the arrow. The peeling starts from the opposite side, and since within the light trephination mark there is no side port, it can be done up to 80-85% like in usual phakic donor tissues. The peripheral redundant DM is removed and the graft is lifted from the underlying stroma, and the final 8mm trephination is much easier, and there is a scope for peripheral trephination of DMEC graft also. Here you can notice that the final trephination was eccentrically placed. Important practical tips. Sometimes the side port may hinder the peeling. To prevent any radial tear, extra effort is taken to clear it like a Nike sign or a tick sign and then proceed further. This will have no effect on the final graft trephination. Or it might be a good idea just to stop there, maybe at 40-50% of the peeling. And then the rest peeling can be done within the smaller final trephination zone. In all pseudophakic donor tissues, the final DMEC graft is made by eccentric trephination either towards the nasal or inferior cornea. Earlier we have shown that eccentric trephination is better in terms of post-op endothelial cell density. In the past few years, we have used 46 pseudophakic donor tissues for DMEC due to shortage of phakic donors. The donor preparation failure is 4.3%. Post-operative endothelial cell density at 6, 12 and 24 months are almost comparable to that of phakic tissues. Now coming back to the initial question, we did indeed use the donor corneas from the 68-year-old gentleman since the specular reports were very good. So finally, do not say no to pseudophakic tissues. Retrieve the tissue, evaluate them. If there is a good specular image, prepare the graft as shown in the video and go ahead with DMEC surgery. Thank you for watching.